Welcome everyone to tonight's presentation. We'll get started here in just a few seconds. Just waiting for everybody to kind of funnel in the room. Well, welcome to tonight's Woo You presentation entitled Glaucoma Past, Present, and Future, Assimilating New Data About Diagnosing and Surgery in the Interventional Glaucoma Era by Dr. Philip Garza. And I'm Dr. Carolyn Major. I'll be your host for this evening. I want to give a special shout out and thank you to Glaukos for providing an educational grant for this event and sponsoring this event. We could not have free CE without them, so thank you very much to Glaukos. There's a few housekeeping items before we get started. As a friendly reminder, for each hour of CE, attendees must be online for a minimum of 50 minutes. And for COPE certificate, you need to fill out the survey link in the chat that will pop up at the end of the presentation. Also, once the webinar ends and the web browser closes, the survey will automatically pop up as well. So you need to make sure you fill that out at the end in order to get a COPE certificate. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. We'll also display a QR code at the very end of the presentation. So if you have the OE tracker app on your phone, it has to be the app. It can't just be your camera phone. It has to be the app camera that you're using to capture that QR code that you can get credit immediately. CE certificates will be emailed within 4 weeks. And please ask questions throughout our presentation because we are going to have a live Q&A at the very end of this session. You can ask questions by using at the floating panel at the bottom, the little Q&A tab, or in the chat. And if you're attending from your phone, you can also ask questions by using the little Q&A icon in the upper right-hand corner or typing them in the chat using the 3 little dots in the bottom right-hand corner. And without further ado, I'd like to welcome our speaker here this evening, Dr. Philip Garza. He's a board-certified, fellowship-trained glaucoma and cataract surgeon. He specializes in the marriage of modern glaucoma surgery with advanced technology cataract surgery. And he offers complete medical and surgical care for glaucoma and performs the full range of glaucoma surgery techniques, from glaucoma laser procedures and state-of-the-art MIGS techniques to traditional procedures like tube shunt surgery as well as trabeculectomy. Dr. Garza graduated summa cum laude from the University of Miami and is a proud graduate of the Emory University School of Medicine. He received his MD magna cum laude in conjunction with the Master of Science degree in clinical research as part of his dual degree program sponsored by the National Institutes of Health. And Dr. Garza went on to complete his ophthalmology residency at the world-renowned W.K. Kellogg Eye Center of the University of Michigan, followed by a year of intensive glaucoma clinical and surgical fellowship training at Stanford University's Bayer's Eye Institute. Dr. Garza is a member of the American Academy of Ophthalmology, the ASCRS, and the American Glaucoma Society. And as a trained clinical scientist, his research has been published in the American Journal of Ophthalmology, Ophthalmology, Glaucoma, and other medical journals. And Dr. Garza lives in Atlanta with his wife and daughter. And it's my pleasure to welcome you, Dr. Garza. I'll pass it on over to you for this evening.
Well, thank you so much. Thank you so much for meeting with you. And we have this financial disclosure slide. I am a consultant for Alcon. We'll get this out of the way. And I've done an ad board for AbbVie. I am not going to be talking about anything related to my consulting with Alcon or AbbVie. And for the next slide. Hopefully, there we go. All financial relationships have been mitigated. So without further ado, thanks for having me. It's a pleasure to be here. And my goal with this is sort of to provide an update on the state of interventional glaucoma. Kind of looking at what I consider to be the past, where we are now in making additional transitions, and where I think we're headed in the future of our field. And so I specifically am going to be focusing on new data in the present section of the discussion, new data about diagnosis and surgery. that kind of fits into our new interventional glaucoma era. Um, so I think that I'm going to go ahead and give you, we talked about financial disclosures, but I'm going to give you my real biases up front. And so I can't about the practice of clinical glaucoma. And so my perspective on practicing interventional glaucoma is that minimally invasive interventional glaucoma techniques can be considered for almost every single patient at nearly every stage of their disease. What I take for granted that you already know, and I think we're all feeling this increasingly these days, is that there is an absolute crush of glaucoma patients that we're already feeling in the 2020s, and that is not going to let up as the baby boomers continue to age. And the number of glaucoma surgeons in the pipeline doesn't get any larger. And so I think that we all sort of take for granted that the number of patients needing expert level care is getting bigger and bigger and bigger. And the question becomes, how are we going to meet this demand and stay and bring technologies to patients? And I strongly believe this is going to require a new era of collaboration and co-management between surgeons and our optometric physician partners. I think it's the only way out of this, and it's the only way to deliver the care that patients need. And what that is now going to require us as ophthalmologists to do is number one, be open to the idea of optometric partners practicing at top of license, engaging with optometric partners in the community, and fostering true partnerships and relationships with individual optometrists within our regions. We need to be communicative and accessible to those doctors. And most importantly, we need to be willing to share knowledge and empower our optometric partners to do the things we need to get your help with, which is basically identifying disease appropriately and in a timely manner. And really, tonight's presentation is about sort of promoting point number four. As far as how to take care of glaucoma patients, I firmly believe that patients with glaucoma deserve access to the full range of therapies available at each stage of their disease, for each of you that you have a glaucoma surgeon partner who's really accessible to you, and I should not believe that and just MIGS and tubes. I think that there's still, and we will get into that colectomy, and we will get into that later, and the evidence for that. I think that the treatment strategy should be individualized to each patient based on their values. And just like having strong partnerships with our optometric physician partners is important, having is key to selecting that optimal treatment strategy. And then kind of in my role, wearing my cataract surgeon hat, I believe that glaucoma is not an absolute disqualification for refractive cataract surgery, but of course, managing expectations is key. And my perspective is currently rooted in my practice milieu, which is Thomas Eye Group in Atlanta. We are a big group. These are all it's a 50-year-old optometrist, 37 optometrists, 20 MDs, and among those, two MDs are glaucoma surgeons, sort of two of us, and then do the two grab type thing, and then the third does everything else. It is a vertically integrated optometrist model, surgeons together, and the optometrists in our practice provide vision care and primary medical eye care. And the ideal here is that the MDs are surgeons, and that we spend as much time as possible doing only the things that we can do. And one of our ways of doing that within the glaucoma division is to have partly subspecialized glaucoma-focused optometrists. I believe at least one or maybe more of whom are on this call tonight. So this is our approach, and that's not a plug at all, but we're growing and we're growing quickly, and we always need help because there just seems to be more and more patients needing our help. We are committed to the interventional mindset of glaucoma care and to the collaborative care model between ODs and MDs that is going to be required for us to properly deliver interventional glaucoma at a meaningful stage. That directly, our group was very integral in the first Business of Interventional Glaucoma meeting that happened in April in Los Angeles as part of the ASOA ASCRS meeting, and this is a scene from that meeting. This is our CEO, Ben Seals, and my partner, Dr. Dana Wallace, on the panel, and I'm somewhere in here. But this was a pivotal moment because that was the first Business of Interventional Glaucoma meeting ever. We're happy to sort of relay that there's going to be a second edition happening at AAO in October in Orlando. So this is not over, and I suspect it will stop there. It will not stop there. So I described to ChatGPT sort of verbally practice relationship and how we work. And this is the summary that it came up with. I mean, I have no idea why, collaborative needs to have two eyes here. Optometric is really present. It's here twice. And for some reason, I'm lasering a hydrus. I don't know what's exactly going on here, but you get the idea. It's a team-based approach. So this is our outline. So this is our outline for tonight. I will start by talking about what I consider to be the past and what I assume that you know, but I think is very important to go over, which is the foundation for where we stand today in glaucoma care, and then move on to the present, which is new information about diagnosing glaucoma and some non-MIGS type news that sort of dubbed the MIGS in number one. And then we'll finish up with talking about where I think we're headed as a field and the things that are not yet ready for prime time, but I think are coming. And so let's start talking about what I consider to be the past, which is laser trabeculoplasty and the basics of interventional glaucoma. The true basis for how we're practicing interventional glaucoma now is the LIGHT trial, which is sort of old news now. It came out in 2019 in the Lancet, just as a review, the LIGHT stands for lasering glaucoma and ocular hypertension. It was a prospective, unmasked, multi-center, randomized controlled trial conducted at 6 centers across the United Kingdom. It enrolled from 2012 to 2014 and enrolled 718 patients who were either randomized to treatment with SLT as first-line therapy for glaucoma or ocular hypertension and medications as initial treatment. And there was a sort of computer algorithmic-driven model that basically allowed patients to receive repeat SLT or additional medication, repeat SLT or additional medications, they are not at target. And so it was a sort of very regimented way of controlling how patients were treated, but still allowed for patients to have escalation of therapy. And what it found was that after 3 years, 75% of SLT patients were drop free. And so, what that means is 75% of patients who it's all they need is SLT. It's all they need is SLT. It's for 3 years, which is a huge necessity and certainly not something necessarily SLT. In addition, SLT patients were at of their targeted clinical trial, and that was the time through the clinical trial, and that was compared to 91 initially. But the real sort of first eyebrow-raising data that came out of the original publication of LIGHT is that 11 medication patients went on to need surgery, but none of the patients in the SLT arm needed surgery to control their disease, which was very, very surprising, I think, to us. Subsequent publications sort of have fleshed out what this really means for our field and for just sort of time's sake, I'll jump ahead to the Wright paper that was published in Ophthalmology in 2020, which was the first follow-up study or follow-up publication from LIGHT that showed that SLT may delay visual field progression. And I want to take a moment to emphasize that this is the holy grail of glaucoma research. It's very difficult to design a study that shows differences in progression. What we're doing is trying to show that interventions that we undertake lower eye pressure equivalently to timolol or to latanoprost, but it's another level of it's another level delays progression of disease. And this signal came out of the original edition of the Light trial in this follow-up study. And this was a difference in progression on visual field, similar IOP targets treated with something else. So something that means something else other than IOP is going on here. And the thought is that there's probably imperfect adherence among medication users, and there may be better diurnal stability of IOP. And in fact, the 6-year results of the Light trial were presented in October 2024 at A in October. And for the result, AAO confirm meaningfully less progression in the SLT group. So even after 2020, this data just keeps showing us over and over and over again, no matter how long we follow these patients, that there is less visual field progression in those patients who are originally treated with SLT. So this is what I call the Tao of Light. We have to recognize that this is a pivotal trial in glaucoma. It is as big as any other study. It is as big as any other study, and it should drive in our field, and it should drive a shift in the glaucoma paradigm. My takeaways are that SLT is better as early therapy than as adjunctive therapy as we had used it in the past. And that's probably true for other interventional techniques. Now, we can't say that with as great of certainty as we can about SLT, but the principles are the same, right? The things that you can do procedurally that take adherence out of patients' hands and provide 4-hour pressure control are going to yield better results for those patients long term. And so that means adopting those early will produce better diurnal stability, and that action of getting patients to intervention sooner will save some patients from filtering surgery. And what this becomes is the goal of stringing together a series of stage-appropriate interventions over the course of the patient's glaucoma journey, minimizing risk at each step and maximizing visual outcomes both short and long term. And my personal goal is to sort of relegate eye drops, topical medications, to adjunctive therapies along the way as you go from step to step on the interventional journey, from sort of technology to technology. And so here is my surgical decision-making and treatment algorithm currently and so for mild stage disease as initial therapy. This is where pharmacotherapy, topical pharmacotherapy used to sit, but now it's laser trabeculoplasty. And it's not just me who's saying this. This is a paper that was published earlier this year by colleagues of mine who I'm not in direct practice with, but who I know very well. And it's interesting because we at Thomas Eye Group had created our algorithm for interventional glaucoma and how we want glaucoma to be treated across all stages in our system-wide. And then this paper came out right at the same time that we came up with our consensus, and it's the same algorithm. And we had no interaction with these folks at all when drafting it. So I think as a field, we're converging on the same idea. Interestingly, that's not the only in SLT. Many of you probably already know about SS, but the Belkin or Alcon now Eagle is a OCT-guided transcorneoscleral SLT delivery device that provides a 360-degree treatment of the trabecular meshwork in less than 3 seconds. Unlike traditional SLT, there's no gonioprism, there's no goniosol. All you need to do is put proparacaine in the eye and a lid speculum. And it does produce similar IOP lowering effect as the more difficult to administer traditional SLT. There is the same or less discomfort than traditional SLT, and certainly better ergonomics for the patient and the provider. One little note about the similar IOP lowering effect is that in May, the GLORIOUS study, GLAURIOUS, was published, and it actually show that direct SLT did already fail to demonstrate non-inferiority to SLT. But if you limit the 12-month analysis to patients who didn't have protocol deviations, that yields essentially the same IOP reduction. So I think that study gets a little bogged down in sort of non-important details, and the takeaway is that they do produce similar IOP. I think we're going to need additional studies to prove that, but I want you to be aware of that research that was published. Speaking of ergonomics, no oculars on the provider side of those. Really excited to eventually adopt this technology.
Hey, Dr.
I'm going to move on now from sort of the underpinning.
Your voice is becoming
I'm hearing a voice. Muffled. Okay.
Perhaps try
See
disconnecting
if
the
I can
additional
turn up my.
speakers and maybe just use your computer audio.
Okay. Is that any better?
Sounds good for now. Yeah, well, I'll let you know if anything changes, but sounds good. Thank you.
Okay, I'll try to speak up. So moving on from SLT to sustained drug delivery, which is part of our interventional glaucoma paradigm, the OG, this is where it fits, sustained drug delivery on my treatment algorithm. And in here, you'll see that in this area, I've relegated topical pharmacotherapy to adjunctive pharmacotherapy very purposefully. Durysta is the OG of sustained drug delivery. It's a intracameral implant that's biodegradable. It's the same material that the retina doctors use to deliver steroid into the vitreous, and it is biodegraded to CO2 and water. Concentration in the AC that is 4,400-fold higher than topical generic bimatoprost. Its clinical effect lasts 9 to 15 months, and it is FDA approved for a single administration. And that's important because on the clinical trials that sort of underpin Durysta, there was some concern for endothelial cell loss in that trial, which was probably due to the way they designed the study. There was sort of stacking of free-floating implants in the AC because they followed a fixed time-based sort of re-injection regimen. So they had multiple implants kind of banging around in the AC. For this reason, most surgeons I know will implant Durysta more than once, but we wait until the original implant is gone on gonioscopy. Just so you're aware, if we do implant it more than once, reimbursement can be an issue since that's the Durysta implant. It's famously the size of the eye on the dime, it is implanted at the slit lamp. And here's IconMed doing it in his clinic. And sort of time to level up on sustained drug delivery, and I'll kind of move on to talking about iDose TR, which is a surgically placed removable implant that does not free float in the AC. Is a advantage. And everything about this device was precision engineered from the ground up to provide a stable, predictable elution of preservative-free travoprost into the AC. And geez, you're looking at this beautiful image device. It looks so huge. And a drop of medication is multiple incredible. And this is how it's delivered. The delivery approach for iDose is different than that for Durysta. This is a tiny device that is surgically implanted into the TM in the OR through a clear corneal incision. And here it is going in. I just did one of these today. And this is what you get. You can see it at the slit lamp. We aim for the suprarenasal angle, so it's observable and we sort of know that it's where we intend it to be. And it provides 2 to 3 years of sustained drug delivery. It is implantable at the time of cataract surgery or as standalone, and it is removable at any time. There was no significant endothelial cell loss in the clinical trial. And importantly, this is not MIGS. This is pharmacotherapy. It's a different mechanism of action. And it's important that we think about this SLT and synergistic with SLT and many future options for treating the patients down the line. Potential downsides, the trip to the OR, for me, that's a positive because I like a controlled environment for delivering anything into the eye. Cost is a potential issue, although there's a very clear sort of patient population who has good coverage for this. My prognostication about iDose and Durysta is that they are just the beginning. I think the future of this, I think the future of this is that we're going to have devices and implants that elute multiple drugs. And so I can imagine a future in which we start a patient with one injectable pellet, we say, or a device, and we say, oh, well, your pressure isn't quite good enough on this one medication, or you're progressing after a period where you were stable. You need more than one agent. So we're going to bridge you with topical timolol, for example, and for a change out, we'll put a two drug device in for you this time. And I think we all see this coming, and it's a very exciting potential future. So, kind of to finish up interventional glaucoma and looking backwards at where we have been over the last few years, I want to talk about standalone micro-invasive glaucoma surgery and invasive glaucoma surgery. And this slide is designed to provide some of these devices and techniques based on whether or not the technique is approved for use without concurrent phaco. You can see that really all of our techniques are approved for concurrent phaco for iStent inject and Hydrus, but notably iStent infinite can be used outside of a concurrent phaco emulsification. We will spend a significant amount of time sort of talking about these devices in the box here. And another way we can organize these devices in our minds is by mechanism of action. I think this is a good way of helping you keep this all sort of straight and know what the options are for patients. So iStent Infinite has been the cool new addition to our standalone MIGS armamentarium for the last couple of years. And it's actually billed as the first device of the interventional glaucoma era. And it's basically three stents that are essentially the same as the stents that were used in iStent inject, except you get three of them instead of two. And this is a slide on practical considerations for this device. It is FDA approved for any stage of open-angle glaucoma and any lens status. That's very freeing. It does require a patient to have failed both medical and surgical therapies, of SLT or a single administration of Durysta, for example. And treatment failure on the medical side can be ocular surface disease or drop intolerance. So, you know as well as I, it is not hard to achieve these goals because of how hard it is to treat this disease and how many side effects our topical therapies can have. So the iStent Infinite is cool, versatile, and relatively new. And another technique that doesn't get enough press in this space is the potential for canaloplasty trabeculotomy to be a standalone intervention. Omni is one of the devices that does this. Omni really is an interventional glaucoma device, but I think we fail to see it that way to a certain extent. And we are still, I think, largely using it in combination with phaco. Works. We go into the eye. We canalize, taking a small goniotomy and then threading the catheter in. And then when you retract the catheter, it injects viscoelastic and performs a canaloplasty. And then before the catheter pops back out, you can just rethread it and then use it to create a trabeculotomy, which is basically a multi-clock hour goniotomy. There's actually a new entrant into this space earlier this year, the VIA 360 from New World Medical. But for our purposes today, we'll think of Omni and VIA 360 interchangeably because they have the same mechanisms of action and indications for use. These are intended to be of action devices, addressing multiple points of resistance to conventional outflow at both the level of the trabecular meshwork through the trabeculotomy and distally in the collector channels and Schlemm's canal through the canaloplasty. It's key that these techniques are FDA any lens status, just like the iStent Infinite. And it's a highly customizable technique because you can do as much or as little trabeculotomy as you want. And in fact, the VIA 360 goes a step further because the surgeon gets control over how much or how little canaloplasty is done because it actually uses a button that delivers viscoelastic on demand. So you can hit that button not at all. Well, I don't know why you would do that. Or you could hit that button a lot. and get a
Hey,
lot of
Dr.
get a
Garza,
lot of canaloplasty.
I'm so sorry to interject. We're getting like a lot of echo on our end. Is it possible you could like disconnect your external speakers perhaps, or can you check and see if you're joined in Zoom, like both in the app and like on your browser perhaps? Like it just sounds like we're hearing you twice sometimes. I'm so sorry.
Interesting. Okay. It's okay. So my app on my phone. So I think what I should do is I will briefly go on pause and
Sure,
then I'll just pull out my laptop and use the webcam on my laptop. I think
that
that's the
works
best way to do
perfectly.
this. Yeah,
Yeah,
give me 1 second. So
you
little
bet.
intermission.
No problem. Thank you. Sorry, everyone, for the short delay there, but we want to make sure we hear all of his expertise crisp and clear. We just 1 minute, we'll have Dr. Garza join back on here. Again, as a friendly reminder, if you have any questions about the lecture, please feel free to put them in the Q&A so that we can get to those at the end of the event.
All right. So I think you might be seeing my speaker notes now.
Yes.
Okay. So let's see here. How about now?
Perfect. You know what? And the sound is beautiful. Thank you so much. Sorry for the interruption.
No, no, all good. So, yeah, you have to have some excitement here. Although I think interventional glaucoma is plenty exciting, right? So, we were talking about how Omni and Via 360 can be sort of customized to how much or how little treatment you want to do. And there's a basis for using these devices in pseudophakic patients, and that's the Romeo study, which specifically applies to Omni. It was a multi-center, retrospective, stratified observational study, and it looked at patients who had IOP of less than 18 or over 18. Notably, these eyes were not super sick. The mean deviation was greater than -12. The cup to disc ratio was less than or equal to zero point 0.9. It couldn't be like a totally cupped out disc, but it did allow patients to be on up to 4 topical agents and have IOP up to 36 millimeters of mercury. Just checking in. Can you hear me? Still hear me well?
Very well. Thank you. It's much
Perfect.
better.
Okay, perfect. And so the protocol did require a minimum 180-degree canaloplasty and a 90-degree trabeculotomy, which is usually what we're trying to aim for anyway. And the result was quite impressive that there was a greater than 6 millimeter of mercury IOP lowering for patients who fell into the greater than 18 group. Now, for the patients who were in the lower IOP group, what it did was result in a half to one medication reduction for those patients. But it's sort of a wow for me that it works this well in pseudophakic patients with high IOP, which I don't think we sort of take advantage of enough. And so in my hands today, this is sort of interventional glaucoma as I practice it. In the clinic, I can do SLT or Durista. In the OR, I can do iDose, iStent Infinite, Omni and Via 360. And I'm aiming in that case for a 360-degree canaloplasty and a 180-degree trabeculotomy. That's what I really try to deliver for patients. And with phaco, I do Hydrus. We do micropulse laser, which is I consider to be a micro-invasive like technique, and then minimally invasive blood forming surgery, or MIBS, with Zen. And so let's review. We basically have the Tao of light. It has given us sort of the underpinnings for the interventional glaucoma era and has changed our mindset about early intervention. There are new techniques even available in the SLT space. iDose is now here to provide 2 to 3 years of sustained drug delivery, and iStent Infinite and other technologies are available for use as sort of complementary techniques augmenting outflow. We often fail to consider that canaloplasty, trabeculectomy is also a technique that can be used at any stage of disease. What I would encourage you to do is you can think synergistically for patients on more than one med. I think a lot of us get excited about the idea of preventing the patient from needing a single medication or taking them off a single medication. But I think it's important not to forget that even for patients on more than one medication, you can combine mechanisms of action such as iStent Infinite and iDose and get that effect. You can take patients from 2 or 3 meds down to zero. And that's just as early line intervention, and that doesn't require blood forming surgery. And if you need it later, you can do it. Something new is always coming in this space. Viva la revolution. So moving on to the present, this is sort of looking at new info about diagnosis and surgery that complements the interventional glaucoma techniques we discussed. And I'm going to start with new info about diagnosis. And I'm going to actually start with something that's potentially boring, but I think is really important, which is the semantics of glaucoma suspect. And it's a really troublesome term because it connotes neither a disease state nor specific risk factors. And so I think we use it in a couple different ways. We can talk about glaucoma suspects as patients who have certain clinical features of optic neuropathy, but it's not yet definitive, or for patients who have significant risk factors, but without those clinical features of a glaucomatous optic neuropathy yet. And it's just muddy. It's a muddy term. It hinders clear communication with patients as well as the other doctors we're working together with about what we really think is going on with the patient. And so I thought this was a great idea that came out last summer in ophthalmology glaucoma. And it really splits the terminology into, well, what features of glaucoma do you think the patient has? And that's one axis. And the other axis is, what are their risk factors for either developing glaucoma if they're a suspect and they don't have manifest disease yet, or for progressing once we say they're having manifest disease. And features of glaucoma really emphasizes our diagnostic technologies that most of us now have access to, RNFL and ganglion cell complex OCT, to talk about changes in optic nerve architecture. And so this is a table from that paper, and basically the split is kind of this way. The features of glaucoma optic neuropathy is one axis of this, and the other is to sort of list out the patient's glaucoma risk factors. And I'll just take a moment to talk about the features of glaucomatous optic neuropathy and how we can be more communicative about this. We can say, well, the patient has nerve fiber bundle or retinal ganglion cell defects that respect the horizontal meridian. And you can say that that's what's making you concerned about them having glaucoma. You can talk about some morphologic sort of something you observe on exam, like localized thinning of the neuroretinal rim, notching, for example. Or you can say, hey, there's change over time with progressive loss of retinal ganglion cells or axons on OCT. And so that basically means that you classify every patient based on 2 axes. And what's really nice about this is it clearly defines the current state of their disease and addresses the risk for future conversion to glaucoma or progression. And it's not part of ICD-10 yet. I think this is somewhere we're going to head, but you can consider using this as a cognitive framework and including these 2 axes in your notes. It's super helpful to your friendly local glaucoma specialists who will understand instantly where you think this patient is at. Moving on sort of from the semantics to new information about old tests. And that's kind of encompassed by the FAST-PACE study, which came out in ophthalmology in 2024. And it basically addresses the problem that visual fields are labor and time intensive, they're psychometric diagnostics, and they have a bunch of variability. We all know this, we live in this world. But the really scary thing is there was a paper in 2017 in ophthalmology that says, well, if you test a patient annually with HVF, it takes 5 years to diagnose progression on average. This is terrifying, and it hasn't affected our behavior at all. Most of us are still getting annual visual fields. If you do 3 visual fields a year, it decreases the time to diagnosis of progression to 2.6 years on average. And if you do daily testing, it'll take you 11 months. This is terrifying. Has not affected at all the way we're practicing. And that's what FastPace tried to address. And so the question that this paper asked was, what is the optimal testing strategy and frequency to determine if the patient needs initiation or escalation of therapy? It was a prospective longitudinal cohort study enrolling 125 eyes from 65 glaucoma patients. And the primary outcome was a diagnostic accuracy of a two-part clustered battery of diagnostic tests that were separated by 6 months. And it looked at patients over 2 years, but the testing strategy that was being evaluated happened at time of enrollment and 6 months later with a series of clustered intensive testing at that 0 and 6 month mark. And it involved both 24/2, 10/2 visual fields, as well as OCTR NFL, notably not ganglion cell complex. So what this ultimately showed is that of 35 eyes that progressed by the end of the 2 years, 25 had progressed during the 6 months using this clustered strategy. Of 90 eyes that did not progress, 85 did not progress during the first 6 months. And so that gives an overall sensitivity of this sort of clustered strategy at 71% and overall specificity of 94%. And you can play with this a little bit by doing either 4 testing sessions, that's a lot, I know, at the beginning, or 3 testing sessions at the beginning for the 0 and 6 months mark. And if you do 4, it identifies 75% of fast progressors within the first 6 months. And so, statistically speaking, this is a much more powerful way to test. We have to start thinking about this and using more clustered testing strategies. Now, this basically graphically represents what they were able to find, which is that if you cluster tests in the first 6 months, you get a slope of a line that approximates the true slope as measured out over a longer period of time. You get an idea of whether these patients are tanking. And so we need to do a better job detecting fast progressors. We can separate disease from healthy more efficiently as well. Of course, there are practical challenges to globally applying this. There's the concern about whether you'll get reimbursed for doing this much visual field, getting patient buy-in to come in this often. And of course, the idea that visual field is a limited resource in our practice. But this is more of a challenge to us. This is a question of how are we going to adjust what we're doing, because one time a year testing is going to fail some patients. 24/2 is also not enough. This paper showed that 10/2 contributes. We can't keep doing it this way. And my feeling is that we really need to take advantage of new technologies, such as virtual reality headsets. This is the Radius XR, to sort of add more testing capacity to our clinics, and then using technologies that have existed for a while, like guided progression analysis that's available on the Zeiss devices. And that, I think, is how we're going to get away from how difficult this is to practically deploy. Now moving on to new information about glaucoma surgery. And this is sort of heavy-hitting traditional glaucoma surgery, and we're going to start by getting totally tubular. This is sort of a recap of the Ahmed versus Barveld study with a twist. And so in this case, what we're talking about is tubes that are valveless. So valveless tubes are tubes that do not have a check valve on them. They are sort of widely understood to achieve lower IOP over the long term than valve tubes. There's less incidence of hypertensive phase than there is with valve tubes. And they basically rely on encapsulation by tenons to provide resistance to flow after the first 6 weeks of healing. And so that means there's a limited eye pressure lowering effect initially, because we have to ligate these tubes, because if you don't, the only resistance you're going to get is nothing, and they're hypotenuse instantly. That ligature is usually a vicral suture that opens at 5 to 6 weeks. There is technically a higher chance of hypotony versus valve tubes, but you can put a ripcord suture down the barrel of these tubes that you can pull out later at the slit lamp that provides some safety factor and flexibility for hypotony. And so what this study looked at was the Ahmed ClearPath tube, which is a new valveless version of the valved Ahmed FP7 tube. And it comes with a preloaded ripcord. It comes in small and large sizes, just like the longstanding market leader in valveless tube shunts, the Barvelt, which has been around for decades, also comes in small and large plate sizes. And just to give you an idea of what we're talking about, these are the Barvelt 350 and 250 tubes here and here. And this is the valved Ahmed tube that's been around a long time. And you can see, the form factor is much smaller for the Ahmed valve. And the idea here was that New World wanted to create a tube that had an improved form factor over the Barvelt, but was also valveless. And so they came out with the Model 250 and the Model 350. You can see the Model 250 is very similar to the valved Ahmed tube because it's single quadrant and doesn't tuck under the muscles like a Barvelt. Any Barvelt has to tuck under the muscles, which has been a long-standing sort of annoyance of those tubes. This was a single center retrospective comparative study of 128 eyes, and roughly half and half got randomized to, or roughly half and half received the Ahmed ClearPath versus the Barvelt. Interestingly, most of the Ahmed ClearPath tubes were the little one, and most of the Barvelt tubes were the big one. And they looked at surgical failure, progression to no light perception, or need for reoperation or implant removal. And there were no differences in surgical failure. Both groups achieved significant IOP and medication reduction. And the final pressure, visual acuity, and complication rates were all very similar. The interesting thing about this was the medication number was significantly lower in the Ahmed ClearPath group versus the Barvelt group. Again, these are all valveless tubes, but the Ahmed ClearPath seemed to achieve a lower final medication dependency. And you can see that in this chart. It was on average 2 meds needed for controlling pressure at the end of follow-up with an Ahmed ClearPath, 2.6 in the Barvelt group. And that's so interesting because actually most of the tubes that were implanted in the Ahmed ClearPath group were the smaller ones, the easier to handle ones, the ones that in my mind create less diplopia, less issues with muscles. And this just shows that the complication rate was exactly the same. Six patients failed in both groups. So tubes are a fact of life in glaucoma. The bad news is there's still a significant failure rate with these. There's still a significant removal rate with these. And patients almost always still need meds. The good news is tubes save patients' vision, and tubes are getting better. So innovation continues. And in fact, I know some more information coming out. A year from now, I'll have another sort of update about tubes that I can't share right now. And so it's exciting to know that across the entire spectrum of disease, we're innovating. And it is possible to optimize by sort of the surgeon needs to think about what's the right tube. Should I leave the ripcord in? Should I put the tube in the AC? How many fenestration should I make? Because that's one way of producing immediate pressure lowering with these tubes is to cut fenestrations into the tube that ultimately close. And my hope for you is that you have a surgeon in your market who thinks seriously about these things and tries to adapt the specific technique to the individual patient because there's so many variables. So kind of moving on to the last component of the present, which is an update on trabeculectomy. I don't know how that got there. Trabeculectomy. And so, the Darth Vader of glaucoma. This is a huge study. I think this is going to go down as another pivotal clinical trial in glaucoma, which is the treatment of advanced glaucoma study. It was a multi-center randomized controlled trial of newly diagnosed patients with advanced glaucoma in the UK. The UK is winning all this stuff. Patients randomized 1-to-1 to either primary medical management or primary trabeculectomy. And these were people with really bad disease, mean deviation lower than -12. And the primary outcome measures were quality of life, but also clinical effectiveness, such as IOP, visual field progression, visual acuity, and safety. And so this sought to basically answer the question, what do you do with patients who walk in and the first time you meet them, they have way cupped out nerves and blacked out fields? What it found was there was no difference in quality of life between patients treated with meds or with trab. Pressures were lower in the trab group, but fascinatingly, On visual field, there was a 1.87 decibel advantage for trab over medications, and there was no difference in adverse events between the groups. And, people who sort of malign trab would probably go into this thinking, on average, patients are going to do worse if they have a trab because it's going to snuff them or it's going to cause some complication, but actually they did better. And so this kind of shows this in graphical format. The IOP was lower across time points for patients getting a trab, and the visual acuity was the same across all time points. So this wasn't really hurting people in terms of decreasing their visual acuity. This is the mean deviation on visual field, and you can see this spread happening between two and 5 years, where patients who receive medical management are progressing and patients who receive trabeculectomy are not. So the trabeculectomy is not dead. It's a very important component of our armamentarium, and it really must not die. The fear here is that the trab is sort of losing favor, and there are fewer and fewer surgeons capable of doing a good trab. The takeaway is that we're doing disservice to patients by assuming that aggressive medical therapy is their safest option when they come to us with advanced disease. We should consider and discuss trabeculectomy with them. And even if the road does not lead directly to trab, I mean, maybe the patient wants to warm up to the idea. We want to lay the groundwork for an efficient progression from meds to MIGS, in other words, interventional techniques, and then onto something like a Zen or a trab. I mean, we have to recognize these patients may need to move down that pipeline more quickly. And maybe some of them need to go straight to a trab. It is not for every patient with advanced glaucoma, and really a safe and effective trab requires individualizing the treatment plan, customizing the technique, and patients to understand this roadmap of sort of what we do when we meet them and how quickly we need to move on to the next intervention. And I think it's really critical that we have your help helping patients understand that this is a journey, this is not a curable disease. We hop from lily pad to lily pad to avoid falling into the river. And the last component of this is you need a surgeon who can do a trab, which is, I think, the biggest concern. My fellowship mentor published this the year I graduated from fellowship. Trabeculectomy must survive. And a quote from this is, nurturing a trab to success is much like producing a Burgundian wine outside of France. And the bottom line is, we need to be doing these things in order to maintain these skills. And so ultimately, if our goal together is fewer patients that need trab, then we need a surgery that is effective as a trab that doesn't exist. We need patients coming to treatment before advanced stage. That's where we need your help getting these patients into our hands. And then we have to work together with you to take care of them. We're not going to steal them from you. We're going to work with you, right? And then we need to apply interventional glaucoma techniques earlier, things that take intervention out of the patient's hands. And that's a component of you and me, making sure that they're getting to me, but that I'm actually doing the things that I'm preaching here, that I'm actually using interventions that provide better stability for the patient. And we're going to wrap up with what I think is the future, which is genetic testing and AI in the glaucoma space, starting with genetic testing. If you want a one-line summary, it is not ready for prime time right now. And I think more before I say anything else on this, it's really important to know that genetic counseling is essential for these patients. We really shouldn't be doing this without connecting the patient with a genetic counselor, knowing what counseling resources are available in our community. You do not want to do this alone. And other fields are more comfortable with this because they use genetic testing more frequently. But if we're going to do this, we need to be connected with genetic counselors. Currently, the testing is best for patients with sort of early onset severe disease with high eye pressure and strong family history, because those are the patients you're suspecting some sort of gene mutation, Mendelian glaucoma. It's low yield if you test all patients for Mendelian glaucoma, but it can be high yield in the right patients who you strongly suspect. And it can be very helpful to do cascade testing of patients and their relatives to sort of help patients and their families quickly identify who's at risk. And there's already a commercial panel for this through Mass Eye and Ear called the JEDI-O panel. It's $250. You can look this up online from their Ocular Genomics Institute. And so the benefit really is to two groups. One is to close relatives of the patient to know that they need to get treated. And the other is in patients who, for example, have like a mycelium mutation, because we know what works well in those patients. So if you can identify that they are a patient who has their problem with a clogging of the TM specifically, like These are patients who do great with trabeculotomy and it can produce a remarkable effect. And these are people who you would otherwise be sending for a tube or trab, but you wouldn't need to if you knew that the problem was in outflow resistance. The next step beyond this is going to be genetic testing for complex disease, non-Mendelian, not a single gene mutation. Is this coming soon? The idea here is to produce a polygenic risk score, and the ideal would be to identify the 10% of people in all comers who are at highest risk for progression. And this is actually available right now, even on 23andMe. It comes with the 23andMe testing, and it also can be purchased separately through a company called Sionix Bio, but the clinical validation is largely pending. And you could send patients for this now. My problem with telling you to do this is there's no hard evidence on what you're supposed to tell the patient when they get their score back. We just don't know what this means yet. This needs clinical validation. Here's the Sionix Bio website. And so I think that there's a lot more coming in that space, but that's your initial orientation to it. Lastly, AI in glaucoma. Well, there are multiple potential applications. One, and I think the thing that I am maybe most excited about is interpreting diagnostics and integrating clinical data. We are way too data rich. And if we think we do a good job by sort of looking at sort of visual fields from the last 4 years laid out on our desktop or on our iPad or on our multiple screen computer, we are kidding ourselves. Our brains cannot account for all of that statistical variability between those tests. And we are missing things, 100% guaranteed. And we're also not very good at integrating across modalities. Think about all these modalities. HVF 24-2. There's increasing evidence we should be doing more 10-2s. RNFL scans, GCC scans, ganglion cell complex scans. It's way too much. And so there will be a huge opportunity for AI to integrate across this and kind of give us statistical output to tell us if a patient is progressing. The next application of AI is going to be in patient education. I think that this is where it's probably going to come the quickest. Instead of us sort of yammering on trying to teach patients about their disease, it actually can provide verbal interaction with the patient and start with the sort of question, what questions do you have about your disease? And it's actually pretty good at doing this. And there are some platforms that do this now. And then finally, if we're talking about sort of the silver tsunami, the crush of glaucoma that's coming, we are going to need help with our patient flow and scribing. And, many of you may already know about these technologies that are available for scribing, but I want to encourage you to think about the real future of this, which is a virtual disembodied clinical assistant in your ear in an earpiece that's telling you Mrs. Smith in room 6 is next. Would you like to know what her eye pressure is today? You say yes, it tells you, and then you're walking into the room with a little sort of co-pilot in your ear, kind of telling you what testing was done today and whether there's a statistical change in that testing. It's like basically, if you're a fan of the Marvel movies, it's like Jarvis for ophthalmology, optometry. And if you think this is crazy, you're crazy. This is coming. And it's going to be a big boon to us and allow us to be more efficient. Is the future now? Well, there's actually an overlay in ChatGPT called OcuSmart, and you can see it's sort of prompting you. Please upload the visual field and OCT images for this patient's glaucoma follow-up. I'll review them in chronological order and give you an assessment of any progression for any progression of damage. This is totally clinically not validated, and it's not validated in large enough data sets, but this is what's coming. And if you search other GPTs in ChatGPT, that's not the only one. There's a ton. And there are patient-facing ones too, that patients can use. And it just goes on and on. Right now, my feeling about this is just like, hey, I've got something for you that can help you, but it's not ready for prime time. This is not a refined timepiece that you're purchasing. And more is to come, and it will be better. So some parting thoughts. What's new is old. I think that a lot of us think that SLT as first line for POAG is the cutting edge. I don't think so. I think that's very 2019. And then what sort of flows from that is that interventional glaucoma as a concept, standalone MIGS and sustained drug delivery, is what we are doing, what we have been doing, what we should have been doing. What's old is new. And so we think of HVF and OCT as, not cool and new, but we can implement new testing strategies that do better for us in identifying patients who need treatment or who are getting worse. There are new and better tube shunts, new riffs on old technologies, and the trab is still here, and it still is super important, and there's new data for that. I just want to know when it's leaving. And the answer is it's leaving when something's better comes along, which is not anytime soon, probably. And it's leaving when we do our jobs perfectly and get patients on a track of treatment that does not require them to be perfect with drops. What's old is old, the term glaucoma suspect, and the idea of medication stacking. We need to take adherence out of patients' hands. All of us know deep down inside we would not be good at taking 3 bottles of medication multiple times per day. And I would encourage that we should stop drop stacking with med number one. Like, does there need to be a med number one? And the answer is often no. Some things are half-baked, like genetic testing for the masses and practical AI tools, although we're all praying for this to come soon in a good way, and it will. Glaucoma is changing quickly. There are multiple potential options for each patient. Those options are potentially overwhelming to you, to me, to the patient. And the way to kind of handle this is to individualize, to educate patients, and to get them early access to the providers who can take intervention out of their hands and help them not be on multiple medications. That access to someone like me is the ongoing challenge. We are not doing this well yet, and things will get worse if nothing changes. And the reason it's going to get worse is because of the crush of patients that's coming with the glaucoma surgeon pipeline staying the same size. We have to keep up with the times, and surgeons and referring doctors must both practice at top of license. That means that I need to mainly be a surgeon, and I need your help being a clinician. But we need to help you do that. My wish for you is that you have a surgeon partner who is up to date, accessible, collaborative, and communicative. And my wish for your patients is a future with all of us investing in patient education to empower them with the ability to collaborate in their own care amidst what is a very confusing array of options. And I think this is the triangle of success in the interventional glaucoma era. How do we maximize access, equity, and outcome? Well, we need that interventional glaucoma mindset to say we want to relegate drops to adjunctive therapy. We need to educate our patients and help them understand that the nature of this disease, that it is treated primarily procedurally, and that they don't have to be wedded to drops for the rest of their lives for the most part. And then we need collaborative care between our professions because there is no way to do it otherwise. And I think if we do collaborate better than we have, that we can turn this silver tsunami into kind of riding the wave. And I thank you. I thank you for your attention. Hopefully, I didn't lose too many of you with the AV problems, but it's my pleasure to answer your questions now.